really liked today's lecture. It was pretty cool to see the education component that we can use. We see a lot of patients that will come in with these ganglion cysts, with these masses that we talk about, and they've had it either from push-ups, maybe CrossFit or something else. There's maybe some trauma to it, and we're never quite sure. So the education that you gave us today was really helpful to be able to, what's my thought process? How am I going to be able to, educate the patient and then make the appropriate referral? I think if we've learned nothing here with these rounds, it's that we can all communicate much better and do a better job of working together.
And I think a lot of patients, whenever they have a growth in their hand and their wrist, their first concern is this tumor, is this cancer? And I think as providers, sometimes we're almost too much the opposite.
Yeah.
We're too much of, consoling, no, it can't be that.
Mm-hmm.
And I think that was one of the big messages that I want to discuss is, yes, it's most commonly that a wrist mass is usually benign, but it's when it's not that you miss it, that it mattered the most, that we didn't do our job. So I think that was the biggest discussion I wanted to have, was realizing that, yes, common things are common. We're not always looking for zebras, as we talk about in medicine, which are the rare hoofbeats are not usually zebras, are usually horses. Right? And I think the key thing is just making sure that we are aware of what else possibility there is, and then be able to console patients when it isn't. Being able to know, okay, look, this may be concerning, but we're going to rule this out before we do anything invasive. Like we talked about, we don't just stick a needle in something trying to drain it, realizing that it could be something a little bit more important. But as I talked about ganglion cysts, and as I was talking about the patient specifically that we removed the ganglion cyst on, we talked a little bit about post-operative care. What do you see if you have a patient that you refer in for a ganglion cyst excision, and then the post-operative care and management? As a physical therapist, do you recommend to us surgeons, hey, I would rather you splint them or not splint them? What do you typically do from a therapy standpoint as far as recuperation?
Well, our main message and the healing modalities that we use is movement. So if we can keep at bay the atrophy, the problems that come up when we splint, when we stabilize, or when we create forced disuse of that joint, we're going to be in huge favor of that. So, like, if it's at all possible, we'd much rather provide active movement, early active movement with education, and get them in sooner rather than later. We find a lot of benefit when we work sooner, because then we can educate the patient to what they should be feeling, what they shouldn't be feeling. We get to be kind of a touch base and a much easier access point rather than all the phone calls that other providers may receive. We can, as physical therapists, we see the patient usually twice a week. And so any other day, if they had questions or concerns, they call us and let us know. So it's, from an education standpoint, it's going to be very, very big on getting early movement. I'd much rather that, because if I can get people moving better, then they're going to feel better. We're going to be able to get them better quicker.
Yeah. One of the things we talked about is that for a ganglion cyst specifically, you can treat these non-operatively. Mm-hmm. And sometimes you'll see it resolve about 42% of the time, is one of the studies that we talked about. If you had a patient come in, or they called you or looked you guys up and said, hey, I have a wrist mass that's been diagnosed as a ganglion cyst, obviously we talked about that, mm-hmm. ruling out the other stuff.
That does help.
What would be your counsel to them as far as management with the ganglion cyst? Because a lot of them say, hey, it hurts to do push-ups, it hurts to do certain wrist flexion motion. From a non-operative standpoint, what therapy would you kind of prescribe, and what treatment regimen would you go through?
Yeah, I'd look at accommodating the wrist and its movements. Oftentimes we'll see people, if they're in maximal extension or maximal flexion in any behaviors or things that they do, it's a problem. So, common is the push-up. So instead of a flat hand push-up, we'd prescribe and have them do push-ups on a dumbbell or some kind of bar apparatus. I'd honestly look upstream a little bit more as what's going on with the elbow and what's going on with the shoulder, because if both of those are issues, if they're weak or they aren't working properly, maybe they're not moving well, downstream is going to suffer too. And so then you're going to have increased stress. And this is usually a symptom of having increased stresses at the joint. And so in therapy, we're taught to always look above and below the joint of question as maybe something that we can treat and look at and improve. So we're going to look up here, range of motion, stretching, joint mobilizations, and then strengthening of the shoulder as well.
As a therapist, a lot of times you are more of the first catcher before they come and see a surgeon or a physician as far as what the issue may be going on and when you refer. With a patient that comes in with a hand mass, what would be your maybe communication with them and your step process and kind of knowing what the right steps are for them, whether they need to be referred to a surgeon or being able to be managed?
A lot of it's the history. You've got to really dive in, I think, into the subjective, into what they tell you about like how it starts. I'd be very curious to find out how long it's been going on, what kind of experiences they've had with it. Does it come and go? Like what's this history and this behavior? Just even like a family history. Has other people had it? Is there a history of cancer? Because that's going to be our big scary one that we want to rule out early on. And have they had imaging before? Have they been treated before? So kind of putting together that whole picture. And honestly, I'd shoot a text over to you and be like, this is what I've got going on. What do you think? Do you want to see them? These are the things. And so that collaborative care model, I think, really hits it on the head. Can we do better about it?
I think that's why we do these conversations. That's why we do rounds. We do our summit meeting that we do, is just we want to create these integrated networks where we can feel like we can just text message and call and have that communication. I think that's the importance of really good medical community that works together like I feel like we do.
Definitely. It's amazing. I mean, every week we come and every week we learn something new.